I think, again, we have to go back to that first split when we talked about with bone sarcomas and soft tissue sarcomas, okay? Now, the bone sarcomas, there's really two main regimens, right? And you have to kind of know these regimens, because if you have a patient that walks in the door with these, it's really important to get this right, because often you're doing this for curative intent in a young patient, right? So it really behooves us to really nail this, right? And so, one of the really established regimens is the Ewing sarcoma type regimen, and that's a combination of what you would say is VAC with IE, or Vinca with adriamycin and cyclophosphamide in alternating cycles with ifosfamide and etoposide. That's sort of the Ewing's type regimen. And then you have on the osteosarcoma side, you have what's sort of called the MAP regimen, right, or methotrexate, adriamycin, and platinum, which in this case is cisplatin. And again, oftentimes used for curative intent in these young patients. And you really have to get these regimens right, because it's imperative for the patients. And it's imperative even from a medical liability perspective, right, that you do this right. Because if you do this wrong, and you get the treatment wrong for curative intent in a young patient, that is a beyond catastrophe, right? And when I say get it right, I really mean it's important, because when you look at the historical literature in osteosarcomas, for example, when, pre-chemotherapy era, pre-1960s, when these were treated with surgery alone, the cure rate for these, when I'm talking about localized disease, was, 10 to 20%, okay? And then in the post-1960s, post-chemotherapy era, suddenly that cure rate for osteosarcomas jumps into the 60 to 70% range. So there's a huge delta between surgical cure alone and surgery plus chemotherapy, kind of multimodality chance for cure. And that's why I say you really have to nail down the chemotherapy portion of the treatment algorithm, okay? So that's the bone sarcomas, okay? But again, those are rare in the adult population, mostly going to be seen by pediatric oncologists. But on the adult side, where we're predominantly seeing soft tissue sarcomas, there is kind of a generalized algorithm where your frontline chemotherapy is doxorubicin or adriamycin. This is a chemo that's been around for, 50 years now. It is a drug that every medical oncologist is intimately familiar with, because we use it in so many different diseases. We use it in breast cancer, we use it in bladder cancer, right? We use it in a lot of places. In sarcomas, though, it is a little bit of a special drug, because it is very dose dependent. And when I say that, I mean the higher you push the dose, the more chance you have of response. And so when you use the drug in kind of a standard regimen for something like breast cancer, you're using it usually at a dose of 60 milligrams per meter squared every 3 weeks as an IV bolus. In sarcomas, you really have to push that dose up to 75 milligrams per meter squared. And this is actually something I see done frequently in the community when I see second opinions, is they are underdosing the doxorubicin, and they are then kind of giving up on it quickly because the patients don't respond as well. So they'll get 2, 3, 4 cycles, and then they give up on it because the tumor is not shrinking or is growing. And what I then say is, let's go back to this and retreat at the higher dose and see if we can then get a response, right? Because, and the reason that I sort of harp on doxorubicin so much in the dosing is because this is probably the most effective drug in the armamentarium for soft tissue sarcomas. And if you throw away this drug too quickly, you are going to throw away your best therapy and everything else pales in comparison, right? So if your objective is to have your patient live as long as possible with their metastatic soft tissue sarcoma, you want to maximize the use of doxorubicin. Okay. The other thing I will kind of point out is that some oncologists or in the community especially will supplement doxorubicin with Doxil or pegylated liposomal doxorubicin. These are not the same drug, right? I mean, the doxorubicin backbone is the same. It's still doxorubicin, but in Doxil, you get kind of a maximum dose of about 50 milligrams per meter squared, equivalent of doxorubicin, which, as we just talked about, the drug is dose dependent in sarcomas. And so if you are using Doxil instead of doxorubicin, you have to understand that you are not kind of treating to maximal effect. You are treating for then minimal toxicity, right? Which you have to sort of be clear with patients, right? You're saying, I'm not treating for maximum treatment response, I'm treating for minimum toxicity, okay? So it's important to understand that these are not interchangeable. The other drug that is also very potent in sarcomas, and probably the other equivalently potent drug to doxorubicin, is ifosfamide. It's another chemotherapy that was developed about 50 years ago. I will tell you that ifosfamide is not for everybody, right? It is not for older patients. And personally, I have a cutoff of about 60 years old. If your patient is over about 60, you really have to think twice about whether you're going to use ifosfamide, which again is a dose-dependent drug. And so you really have to push the higher doses. And if you have an older patient, they don't have very good kidney clearance, and so the drug is going to linger in their system. It's going to result in nephrotoxicity, and it's going to result in neurotoxicity. So your patient's going to hallucinate. They may have altered mental status, right? The other thing is with ifosfamide, you have to give tons of IV fluids to flush it out. Patients who are older don't tolerate large boluses of IV fluids. They will get volume overloaded. They may end up in CHF. And so you really have to be careful and know what you're doing when you use ifosfamide. And generally, I reserve it for patients who are younger and more fit. But that being said, it is a very potent drug that works in sarcomas. And I will tell you that in certain sarcoma subtypes, ifosfamide is really the best drug, right? And one that comes to mind, one that is not that uncommon in the sarcoma space, is synovial sarcomas. This is a subtype of soft tissue sarcoma that is, again, mostly seen in younger patients, people in their 30s and 40s, but ifosfamide at high doses, and I'm talking about 10 to 14 grams of ifosfamide, that's going to be your drug of choice there, right? And these patients are younger, so they can tolerate it. But if you're looking for maximum response, this is really the way to go, okay? Those are your two heavy hitters. Then you have other next line drugs like gemcitabine, which is a very easy drug to give. I'm sure most medical oncologists are intimately familiar with it. It can be given either by itself or in combination with docetaxel. I find that in that combination, the gemcitabine is probably the more active agent, and the docetaxel is the one that contributes the most toxicity. And so this is a regimen where you start with both, but if a patient develops a lot of side effects, you kind of can dose reduce or drop the docetaxel and go on gemcitabine alone. The other agents are trabectedin or Yondelis. This is another IV medication. It's kind of a microtubule stabilizing agent that works similarly to a taxane. And then there is pazopanib or Votrient, which is an oral VEGF inhibitor. Also has kind of, just like trabectedin, has kind of a little more modest response rates, but on occasion can stabilize disease. There's a couple of other agents that we sort of don't really want to get into right now, but I do want to talk about the kind of emergence of targeted therapies in sarcomas for specific subtypes. And this again goes back to the importance of making a precise diagnosis, right? Because if you have a certain subtypes now have targeted therapies to them, right? And so, for example, mTOR inhibitors in nab-sirolimus has really come into the foray for TSC2 mutant sarcomas. And then tazemetostat is now being approved. That's an EZH2 inhibitor for INI1 deficient sarcomas. Obviously, most oncologists should be familiar with KIT mutations in GIST, gastrointestinal stromal tumors, and now there are 4 agents approved in that category. I take that back, 5 agents approved in that category, right? Talking about imatinib, sunitinib, regorafenib, now ripretinib, and then avapritinib for the PDGFR mutant GISTs, right? So there's a lot of targeted therapy work being done in the sarcoma space that's very exciting. I'm not even getting into the NTRK fusions, right, which are a needle in a haystack. When you find those, it's like, the skies have parted. So there's a lot of exciting work being done in the metastatic setting for specific sarcoma subtypes in the targeted therapy space, okay? And I'll kind of wrap up there and just say that I'm not touching on adjuvant or neoadjuvant therapy in sarcomas because that's a rather controversial topic, and I probably need an hour to just discuss the nuances of that.